Solutions Conversation Series. I am your host, Lauren Gates, and I am so beyond thrilled to have our special guest tonight, Dr. Lauren Ballinger. Our topic tonight is basically airway all day, every day, and whatever may come up in between. So welcome, Dr. Ballinger. I feel like we're kindred souls, and I don't know if it's our name, but I heard you described as being fiercely passionate and an energetic pediatric dentist. So I knew I liked you right away.
I am so happy to be here. And same, Lauren, I feel like we've never actually physically met, but I feel like we know each other. And I think partly is the name. There's not a lot of Laurens, our name. Then a lot of Laurens in dentistry. And then you boiled down even further to airway dentistry. And I have just been such a fan of you and your career and what you're doing and stepping out the box and bringing people together. And I was just so honored to get this invite. So I'm so excited to be here.
Well, you have so much to share, and I can't wait to just kind of roll up our sleeves. I don't have any sleeves on, but roll up our sleeves and really dive into a really inspiring conversation, because what you have done is really, really remarkable in every sense of the word. But what I'd like to start at is, let's go back a little bit, and rather than me read your bio, which is like really long and
yeah, don't even read it.
It's super impressive. I really want to hear it from you. I think so many doctors in the questions, they just want to kind of learn, how did your story come about? How did you go from like graduation to now being so airway centric?
Well, that's a great question. One thing I've learned along the way that I learn every day is never say never. And you really have no idea what the future holds, and to kind of be open with that. I'll go way back. I graduated. I didn't even think I wanted to be a dentist. My father is a pediatric dentist. My uncle is a pediatric dentist. My grandfather, who I never met, was a dentist. And I was always surrounded by dentistry, but it was never pushed on me. But if there's dentists listening, I'm sure some of us have had people in the dental field where you just feel like you spend a lot of time in a dental office and it just sort of becomes the fabric of your life. So when I went to college, I was an environmental science minor, but I loved, I'm a passionate person. I'm sort of a black and white person. So I thought I wanted to be an attorney.
Wow.
And, and I like to talk things to death and, really think and advocate. I think, advocating has always been sort of a background personality trait of mine. But when it came time to think, I was like, man, I just can't see myself just sitting behind a desk and doing research and typing. So I remember I called my father and I said, Dad, I'm really thinking, and as a senior in college, I think I might want to be a dentist. And he just, instead of being like, wow, that's great, he said, really? I want you to come up with 10 reasons why and call me next week, which, looking back now as an adult with older children, I can kind of see why that was. So long story short, I had to, after I graduated college, I stayed in the area and had to take all my science requirements, and I worked for a general dentist. And it was the first time I'd actually been in a general dental office, because I grew up in a pediatric dental office. And so that was a great experience for me. I didn't realize it at the time, because it was my first experience with a dentist other than my family. The dentist I worked for was, at the time, he was a big panky dentist, and his values and details to work and his humanity with patients was so amazing. And, I guess I didn't really know what to compare it to, but it was a really great start. So I went to dental school and I graduated in, 2000. And I met my husband there, who was a year older than I was. And when we fell in love, blah, 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 he said later in dental
We'll have another conversation on that.
Right. But he said, I'm going to Germany. And I said, oh boy, because he was in the armed services. So I knew at that point I wanted to be a pediatric dentist. But long story short, we got married and I worked as a general dentist out in Germany for about 3 years.
Interesting.
Yeah, a lot of people don't know I did general dentistry for a while. Again, it was a good experience for me. I tried to get with the kids, but I did enough general dentistry to realize that general dentistry is probably one of the hardest things out there. And I just am really kid focused, prevention focused. So I did my residency at the University of Maryland, graduated in 2006, had my first baby, worked for an amazing I don't mean typical, she was amazing. Her name is Sherry Cohn. If any pediatric dentists are on this, they might know her. She's very much into the government of AAPD. She was such an awesome mentor and influence in me, and just in terms of, again, very solid care, comprehensive attention to detail. So, that's where I started doing lots of restorative, lots of preventative hospital dentistry. And this was in Maryland. And when it came time for my husband, who's a dentist as well, and I to sort of decide where we want to settle down with kids, we decided to move back to my hometown in Western Massachusetts and I decided to join my father and uncle's pediatric practice. And this is the funny story. I was really hesitant to go back because their practice was at least 50% ortho. And up to this time, I hadn't really had any ortho. I had the ortho experience I had in my residency. In the general pediatric dentist practice, we referred to an in-house orthodontist, but that was really all I knew. Looking back, that was probably one of the best blessings that happened to me, because I got thrown into the deep there. Okay. And I immediately took a yearish mini residency, one of those several weekend warrior courses in straight wire technique. And that really has helped me foundationally move into where I am now. So let me fast forward. So I'm there for about 5 years doing traditional pediatric dentistry, hospital cases. At this time, my daughter is around 8 and my son is around 10. I could give a whole lecture on looking back, if I had known then what I know now, about airway red flags. But it's the Yankee Dental Conference, and I signed up for a course, and it had the word pediatric in it, and it had the word orthodontics in it, and it had a new word in it, airway, and Ben was giving it. And it was one of those 3-hour classes.
What year was this? I'm sorry.
Oh gosh, I don't know. I keep on going back. Was it 2016?
Okay.
Something like that. Okay. So Yankee Dental Conference. I've actually tried to look it up, and honestly, I don't know, because my life has been a blur since this moment. So what I am about to tell you is an absolutely true story, and it is not an exaggeration. So my father was supposed to come to this lecture with me, but for some reason he messed up his ticket. So I ended up going alone. And I sat in Ben's class, and what I remember, because again, it was all such just a catharsis of information, was him starting with, just pictures of faces and a couple medical histories and, a report from a psychologist and school counselor. And like what I remember is I don't think he even showed teeth until the very end. And it wasn't even teeth talking about, it was more of the big picture. And I swear it was like a lightning bolt hit me that, number one, this is what was happening to my children right now. Like all these little nagging issues that I had, it just washed over me. It was a blessing as a mother. And the second thought I had was, and these children are in front of my face every single day. And I walked out of that practice and I found my husband and my father and my uncle. We met for lunch, and I said, like the black and white person that I am, I said, you guys, my mind was just blown. I am never practicing the same, ever. I said, everything has changed for me. Now, my husband, who kind of knows me, took it with a grain of salt. Right. And my father and uncle, God bless, said, what do you mean? That means you're not going to do sealants anymore? No, you don't understand. No. It's bigger. It's bigger than that, right? It's like everything. And from that, I don't know, that was probably a Saturday. And starting that Monday is when I started my journey, not knowing really a single thing, but just setting my intention of how I was going to do differently. And at the same time, becoming a mama bear crazed advocate on how to get my children the help they needed, because I knew that I wasn't prepared to act fast enough for them during my learning journey.
Wow. So it's like once you knew, that's how I felt when I first saw Ben Miraglia, Dr. Miraglia speak. It was just like I couldn't, the box was blown away. You know, when you're like out of the box, you're out of the box, and then the box is not even there to go back into. It like blew away. And you can't, once you know, you can't not know anymore. And you want to scream it from the mountaintops.
Yeah. And it's a really hard, uncomfortable place to be. And I'm sure that I've had so many conversations with peers and, turned into colleagues about this, like, oh no, like now I know this, what am I going to do about it?
So let's talk about that.
Yeah, okay.
Yeah, because that's a lot of the questions I received today is once you know, and I know you went on an incredible journey with your continuing education, but how do you handle the opposition that you face, or when parents come in and say, but I was told by a certain specialist that my child needs extractions? Like, how do you handle, let's just start with retraction versus versus expansion rather.
Okay. So for one thing, I'm really privileged now that I've moved into a space where, and we can talk about this later, where I'm more referral based, which is so pleasant to be in because I don't feel like I have to knock down all these boundaries. I do have to say that it is so hard when you are in, whether you're a general dentist, a pediatric dentist, hygienist working in any kind, how do you start this conversation, right? How do you see a child that looks sleep wrecked and growth is all, like, where do you even start? And I made the mistake initially of being like, this is, just giving too much information. I also have to say that Monday, I had a couple patients in rubber bands, class 2 rubber bands.
Okay, right.
And I did have to say, this I know is not right, but I don't know how to fix it yet. Okay. And I had people looking at me like I was absolutely crazy. So how do I deal with the pushback? Something that helps me a lot is to understand that one, people have to marinate. We had the box, the roof blown off the house. But as parents, this is probably the first time they're hearing it. Like you said, they are not hearing it from anywhere else, including people that they respect very much in their life, like their pediatrician or, their first older child's orthodontist. And, what works for me is just to state it from the heart, to just say, look, I see X, Y, and Z. For me, it's been very helpful because I overshare my journey with my own children, that I missed it. And that if I had known then what I know now, so many painful, unnecessary things would have happened. And to point out a couple things and just to say, I do encourage getting other opinions because I said, there is nothing more important than a parent radar. And if this is speaking to you, then it's the right decision for you. I have stopped trying to upsell or convince because this approach does take such compliance that it's not worth trying to talk a family or a child into doing something for the long haul that they're not ready for, even though that's what our heart and gut is aching for them to do. As far as, oh gosh, Lauren, how many conversations a week do you have with your peers about, like, what do you do about everybody asking for double blind studies? Okay. Yeah. So I was just on a call on Monday speaking to, everybody will probably know, Bill Hang. And here's the thing. What's the, he said is, okay, what's the harm in trying? Like, that's all you have to answer. Like, there aren't double blind randomized clinical trials right now because they're just starting. We haven't been able, this is not, has been in the literature, in the late 1800s and early 1900s, but there weren't these, whatever everybody's asking for. They're happening now. We have case studies. And I think explaining or, having hundreds now of case studies that are saying, we are really improving lives is not worthless information. And you're asking, so if somebody asks you, tell me this, show me the research of why doing it could cause harm. Like,
Brilliant.
what are we doing that can cause harm? Right. So to turn it like that.
But
And
you're also empowering the parent. I really like that. When you're just saying, they have the radar, does this make sense to you? Kind of empowering them to learn more, I think is really a great tip.
yeah, there's no way that we can go through this airway journey with children without having a passionate care provider behind them. It's too hard. It's too long and it's too hard. And I'm not even the young, starting treatment in younger ages is much easier in terms of, what you're going to get and predictable. But kids are growing for a really long time. And honestly, we are just going to start to see what is happening to these 3 and 4-year-olds that we're treating now in 10 years, in 20 years, in 30 years. We don't know. We're making some really good predictions and guesses that make clinical sense because, structurally, if you're deficient or underdeveloped, so are your airways. And we know that children have a limited growth. And these are facts, right? So, I think when you get challenged by another professional, just the fact that a child is not going to have the opportunity to grow for a certain amount of time, what harm are we doing by trying to improve their quality of life right now? They can't come back to that. They don't have to agree, right? And then again, to empower the parent. That's the number one thing.
So when you empower the parent, do you give them screening tools to watch their child, to kind of report back to you?
Yeah. So again, I've sort of moved into this really great situation where parents are coming to me because they've already seen it. And I'll tell you, some parents are so educated, like they just know so much. And frankly, I see the movement coming from parents to parent, really parent groups educating other parents. But yes, when I was in more of sort of a comprehensive practice, saying, as part of your child's routine screening for brushing, flossing, all that stuff, did you know that dentists and hygienists are also clinicians of the structures that border your child's airways, right? The development of your airways. And there's certain clinical things that we can see, just like bleeding gums, and certain symptoms, just like tooth pain, that we can screen for, that we would like to have the opportunity to make you aware of. Are you interested in learning more?
Right.
That's the key. You have to give them the out to say, no, I'm not.
And another thing, I just remember as a hygienist, just speaking to patients, you can tell when parents and patients are leaned in. You can sense it, right? We have a good sense on that.
Oh,
it's
yeah.
not that difficult,
When you get
right?
that.
And I forget, and I wish I could remember. If I do, I will give her the credit. But I was listening to a speaker and she used an acronym, WAIT, W-A-I-T, is why am I talking? And sometimes that really, it's so simple. And sometimes you get so fired up and you just want to kind of share what you know, and you're not getting the reception. Just wait and just stop talking. And you know what? Maybe you can give a little video, that right2grow.org, or do you have any sites that you recommend that you?
Yeah, I love right2go.org. I love the new ADA brochure, pamphlet on airways. Have you guys seen that?
Oh, so wait, I have it all set up here. So basically I have a slide on that at the end to show, and I wanted to talk about that because you were integral in creating that. So actually, let me see if I could just share my screen right now.
And what's really great, you guys, that I just found is a media group. They're called Curtis Media. And
we have we're affiliated with them. We actually have a discount for their
marketing materials. So I just sort of found out about these guys, and I had a great phone call with the founder, and I love it because the screenings are like in little cute cartoon forms, and it's friendly, and it's not like putting anyone on the defensive. And two of my colleagues, Gloria Najadas and Carla Damon, who practice in Texas and Dallas together, and they have a hybrid sort of comprehensive pediatric dentist and airway practice. They have them laminated in their office, and they're having parents say to them, oh, my kid has that. or a child will say, oh yeah, that looks like me.
Right.
I mean, and that's what you want. And I loved it because they are so non-judgy and they're so non-clinical that it just, you can hand it to a kid and say, hey, does this look like, something you recognize? And it's so interesting because kids will start to like circle things that the parents don't believe, like, I am bullying.
Right. Oh, interesting.
Right? Like, I
Yeah.
feel aggressive. And these are, of course, the things that parents will immediately talk over their kids. Like, no, you're not. No, you're not. Because there's so much defensiveness. So
Right.
I
You're just tired, right?
they're tired, right? They're tired.
Yes,
Well,
they're
that's
just
the problem.
tired.
I think at the heart of this, we have to realize that defensiveness, and I know this all too well as a pediatric dentist, it's very hard to sometimes even tell parents that their kids aren't brushing as well as they'd like. The defensiveness comes from a position of love.
Yeah.
Right. And so we have
Ultimately.
to try to get really human and understand that they're not being jerks or there's another story there that maybe we can't solve for them. But what we can say is, I am as concerned about your child as a provider as any other provider. And I just want the best for your child. So if you're ready, great. If not, I am here for you and your child.
A lot of the parents, they don't really want extractions. I think there's something different where they say, is this really necessary? And that's where I think social media can be helpful many times.
Oh yeah.
If you look into it,
And I think just explaining it in simple, like I try to really break it down, like, yeah, I get it. But when you're taking out teeth, it's like you're rearranging the furniture and saying, something doesn't fit. So you're just throwing out your couch, as opposed to, or if you really loved a pair of shoes and your foot didn't fit in it, you wouldn't cut off a toe.
Right.
We're supposed to have this amount of teeth for a reason. And that, just really simply by saying, when you remove that, you are just closing down the space available for your tongue and the borders of your airway. And you're right, I think most parents do not want their child to have to go through extractions,
Right.
whether they understand the airway thing or not.
It's just like an instinct, or maybe they had it done and they don't want to go through the same thing. Right. So they're kind
The
of
other thing that seems to work really well too, when, is to take the focus away from the child a little bit so parents don't feel quite defensive. And when you bring up the conversation, say, I'm curious to do a screening and ask a few questions because I'm curious, do you know anyone in your life that is wearing a CPAP machine? Like, to start it about the adult conversation and then go backwards. And most of the time, yes, they do. And then you'll say, how do they feel about it? They hate it. That's right. So
you go to the
right,
end.
you go back, right? So the questions I'm asking are because you don't just wake up one day in your 30s or 40s or 50s and need a CPAP. Believe it or not, that beginning of that journey starts at birth. And by asking you these questions now with your child, we can maybe help them grow out of the need of having a CPAP. Or, if they said no, you can say, well, anyone have pain and headaches? And usually moms will all go, oh my gosh, yes. Yes.
They
Or I
start to
have to
think
wear
you're psychic, right? They
right,
start
right. I have to wear a night guard or something. Do you like that night guard? No, I hate it. Well, what if we could work to sort of spare your child from that? I'm finding that appealing to the parent and working down versus pointing a finger at their child is working a lot better because it's relatable, and it also, I think, works on that love story where that defensiveness comes from, and that if we can prevent our children from suffering, we will. And if we can identify our own suffering and, kind of get parents to go, oh yeah, they're much more receptive. So that's been a big help for me. Believe me, I learn something new every day, a new approach.
I'm sure. Now you're very involved in creating collaborative care where you are. And I know that's really hard to implement. So tell us a little bit about Endeavor and what you created and how, I mean, I am so excited by this, you know, when I love people who have an idea, launch it, and then it helps thousands
Right.
and hopefully millions of people. So kudos to you on that. Tell us a
Thank
little bit
you.
about
It was
Endeavor.
the silver lining that came out of COVID.
Okay.
You know, just some of us sitting around all out of work, right? Thinking, you know, and, you know, realizing that people were finally talking about breathing and immune systems and mentioning some of the same comorbidities with COVID that we know go with adult sleep apnea, right? So it was actually Kevin Boyd and I started talking, and Dorothy Nelson, like, you know what, people really might be listening. And at the end of the day, wherever you are in your airway journey, and whether you're a pediatric dentist or a general dentist who treats kids, every lecture that you've ever gone to ends with, but you got to start early, right? And how early is early? And how do you know how to do it? And how do you, you know, if you don't know how to relate to kids? So that's sort of where it came from. And thankfully, Howie Hinden and the AAPMD have sort of picked us up as their pediatric spoke. So really what the Endeavor is doing, we're in our infancy, but have some big dreams, is really focusing on the airway big picture of those, we call them 72 months and younger, or, you know, primary teeth and younger, to not only get out, you know, the message that the younger the better, but how can you treat these kids? And one of my big dreams is that I don't want to reinvent the wheel. There are so many, like Ben and you and Bill Hang and Kevin Boyd and Herbert Ramirez and all the different things that are already have so many amazing programs, that when you go to a class, like say, like I did with Ben's, or you meet me and say, where do I start? That you can get on one central place that's sort of not an advertisement, that's not, you know, promoting this way or that way, just saying, this is what's available. This is going to be the schedule for the next 2 years. You know what I mean? So you can kind of look ahead and start really knowing where you want to jump in. You can schedule it ahead of time. It's very hard. There's great classes out there, but it's not easy to find them all. And it's just not accessible for, I think, a lot of dentists, because the reality is that there has to be more people doing this. And the reality is that a lot of our patients for collaborative care have to be willing to travel to get it. And you know, so that's one of the parts of the Endeavor, is really starting to bring that together, starting to bring some of the like essential place of, you know, what research is out there for both parents and providers, just make our lives easier to jump in and get started, and hopefully even like a little mentoring program. But it's not meant to be like Lauren Ballinger's guide to, no, it's trying to bring everyone together, all the great minds together, not reinvent the wheel, just make a place to access it more easily and collaborate.
So how would people register or sign up or become part of that? It's through the AAPMD?
Right. So we get that all the time. Like, how do we want to be a member? And I'm like, guess what? You don't want to be a member right now, because it's a hot mess.
Okay.
Right now, because like, we don't even, we're like, it sounds really exciting, but you know, we meet, and it is, but we meet every Monday. We have met every Monday since April.
Wow.
15 of us. That is crazy. But what we're doing right now, guys, is like bylaws and mind map, you know what I mean? Like trying to do the scaffold so that when we like approach someone like you, Lauren, or Ben, and say, you know, can we sort of bring, you know, your platform as a presence onto this, that we can do that with you being like, all right, let's go, and us not be like, well, we don't even have a place for you to send in all your stuff. You know what I mean? So we're really like working out all the fine details. If you want to be, but one of the things that we did start doing is every second Monday of the month, the Endeavor is putting on some sort of case presentation that talks about focus on early treatment. So, you know, Kevin Boyd spoke on one, Sharon Moore did. We brought in, here's another way to be a part of it. We brought in a general dentist. Her name is Lisa Baines, who kind of has a practice, like she does everything. And she just brought in one case that she did kind of talked it through from thinking beginning to end, had the parents on, just to get people, it's not meant to be a lecture. It's meant to be more like, here's
Like a
some
study club,
pictures.
right?
Right, exactly, for everybody, but really focus on, 6 and under. So it's a great way to kind of get started in that. And believe me, as soon as we have sort of our, our little avenues solid, it's not at all meant to be exclusionary. It's just not as fun as everybody thinks it is right now, because it's like we're really trying to create sort of the pedo version of the AAPMD.
I
So we're
see.
getting there.
Okay.
We're getting
Well,
there.
something to look forward to. But if
It's-
someone wanted to tune in to, say, this raw kind of platform, is there a way, or is it still not open to the public?
Well, it's not open because you know what? We have a really hard time containing our discussions to an
I
hour,
see.
hour and a half, because we're all
Right.
big mouths and think we have so much to say, because we do, right?
Right.
Because we think we
Right,
do.
right.
So I do think, I mean, what we're hoping is that yes, actually there will be eventually, and it'll be more of like a mentoring thing, like a study club with all of us on, where again, you can just prevent a case and we can talk about it. I feel bad that sometimes people feel like it's, the last thing I wanted it to be was some sort of elite. It's not. It's just a bunch of us just kind of grassroots trying to think tank and get some pathways for early treatment, and we're really close. The best thing I think is to be an AAPMD member.
Absolutely.
Right.
Mhm.
I mean, that's another piece of advice. If you want to learn where to start, the AAPMD has so many courses in their library just to start listening. And I know every dentist wants and every hygienist, because this is how our mind works, wants that you do ABC to get the result of D. And it doesn't work like that right now.
Right,
It
right.
just doesn't.
That would be too easy, right?
Too
That's
easy.
right.
Right. It's not like the same prescription of how you do a cavity prep. It takes learning a little, trying a little, understanding that better is great, that you don't have to go for perfection. That's another big tip of mine. Just if you can get these kids a little better, that is a huge win. And maybe what you did this year isn't what you're going to do 5 years from now, but you still made a difference.
Right. And actually, Dr. Miraglia says kind of the worst thing you could do is nothing.
Nothing.
Or wait, or wait.
Right.
It's almost like, wait, what are we waiting for?
Right. We're
So,
waiting for, we're watching smoke, watching it become a fire, and then a 5 alarm devastating, destructive fire.
so what's your recommendation on what age? I know you have, you're creating the dental home. You say you want all kids to be able to have access to care by age 1. Tell us a little bit about your personal recommendations.
To start treatment. Well, so I mean, I hope that every baby, well, let's even before baby, I would like prenatally, when we're all, when you're most people, not most, but some, when you're in childbearing age, you start, whether you think you're going to get pregnant or not, you start getting on the radar about what information is about having a healthy body. It really starts, guess what, with how hydrated, how healthy the mother is. How about this, that is sort of out of my purview, but what about that 3rd trimester sleep apnea that happens a lot? And, the decrease in oxygenation to the developing fetus. These are all major issues that need to be tackled. All right. So from my point of view, you're born, you should be screened for restricted oral frenums. And the way I treat them, again, is very collaborative. I am so fortunate to have a CLC. She's an assistant. She got her certification in lactation consulting. She was the only, in her class, she was the only, there was physicians and hygienists and nurses, and she felt a little intimidated, but you know what? She rocked it, and she just is such an integral part. So we really work collaboratively with that. So reestablishing the nursing relationship if possible. If not possible, talking about early intervention in terms of what kind of foods these babies should eat, making sure you're eating hard foods, really making parents aware, the little things we all know, closing the lips. You know, if you can do some binky education, maybe slide in a, you know, myo brace or a myo munchie trainer, all these little things, but sort of prepare them for. And here's what I believe: if you're born with a like a tongue tie, you're already born under the gun. Your structures are already small because they've developed in utero small. And from my experience, I could be wrong, that just releasing that tongue and establishing the perfect nursing relationship isn't usually enough to overcome that structural deficit, because we don't live in a hermetically sealed bubble. Okay. I mean, there's allergies, there's animals, there's, you know, everything coming into the soup, that when a child is already under the gun, even though we fixed one thing, that we have to be on the radar that that wasn't it. So it starts at birth. If I can ideally start treating, which in the way I start to treat, you know, if you get them early, is with expansion and some AP development. I've been treating some 3.5-year-olds, 3-year-olds, and you guys, it's amazing. 3, 4, 5-year-olds are like the best.
It's like
They're the
putty,
best.
right?
What?
I've seen, just on your website, I've seen some of your before and after, and on your Instagram, which I highly recommend everyone follows you on Instagram on Good to Grow, because you post some nice pictures. You know, seeing is
I have to give a shout out to my social media guru there, Meg,
Okay,
because I'm, yes, no, she does a really good job with that.
but it's
And
a great
I'm
resource
really-
too.
I'm sensitive about showing parents and patients pictures, because I really ask for permission, which I know we all do, because it's a very emotional journey for them, you know, and as we're like, oh my gosh, this is so amazing, or this is so cute, they're still very much in the throes of, because I've been there too, desperation and fear,
Right.
you know, that
Yeah.
sometimes showing these pictures after the fact is a better way to do it, because it's a very vulnerable, scary place for them to be sometimes. But what's so great about these young kids is that they move quickly, they grow, they're adaptable. So that's another thing that the Endeavor is really trying, that we're going to start doing some learning platforms on too, is okay, you know, so you say you want to treat, you know, you say you want to be a millionaire, you say you want to treat a kid, how are you going to do it, right? So I've always said, as a pediatric dentist, the only difference between being a general dentist and pediatric dentist is that you have to know that kids and dogs smell fear. They do. And if you're not afraid, you know, and you're genuine with them, they will be not afraid and genuine right back, right? To me, working with kids is about as pure as it gets, because when you're working with adults, we have so many notions and stuff to unwind, and right, like working with kids, the hardest part of working with kids is their parents, you know, because, and I get it, because parents have so much, you know, going on, just, but the kids themselves are pure and they're wonderful and they are receptive and they love getting gifts and praise, and they start feeling better so much quicker. And it is so nice to see a couple months go by and these children just look different. I mean, we still have a long way to go, but their coloring is different. They're able to sit in the chair, like not jumping out of their skin. I mean, these kids aren't hyper because they're bad. They're hyper because they are, like, you know, their parasympathetic nervous system is shot. They are exhausted and the parents are exhausted. And it's just so nice to see those subtle little changes. It's like the best. So we're going to hope to just do technique and behavior management. How do you do this? Because it's scary.
Right. It is scary. It is scary. And then you get the trust, you gain the trust. And I would say that goes hand in hand with compliance, correct?
Yes. Yeah, it's interesting. Kids, younger kids, you know, with their parents' support, let's think about it, they're in the process of learning to do everything new and sort of navigating the rules of the world, right? And so a lot of times I'll say to parents, they'll say, how are they going to do this? They're not going to like it. And I'll say, well, you remember that first time they tried to run across the road and you grabbed their hand and they sat down and squirmed and cried because they're like, what do you mean I can't run across the road in the middle of traffic? You know, that's outrageous. That's what I wanted to do. But you parented them through that. So, you know, if you set it up in a way that, like, hey, buddy, this is what you're going to do. You're okay. You know, I know you're going to be okay. Dr. Laura knows you're going to be okay. You're going to be okay. they do fine. They might have that initial sort of meltdown like toddlers do as they're navigating the world and hearing no or getting some sort of boundary for the first time in their life, but they're always fine. And then the next time you see them the next day, it's like they love it. And then they love the praise. They love the whole thing about it.
The whole
Yeah.
thing. And then you love it, right? It's
I
like
love
full
it.
circle, right? I
I
can
love
tell.
it. Yes.
So what is your piece of advice for, say, pediatricians or general dentists who are on the fence about starting? They're kind of hearing the buzz about airway, then you have the sleep appliances, and it can get a little overwhelming. So what would be a good first step?
Well, I think sort of figuring out how deep you want to go, right? Because you can do so much with screening. The problem with screening is that you have to find a collaborative team to treat. And that's not easy. And then you start to realize that, and then you start to say, well, maybe I should do this myself, right? Because no one's out there. So I think getting a very good hands-on course like Ben's or Dr. Hang of appliances. I think one of the things we have to realize is there's not a one size or one technique or one appliance fits all. The more tools you have, the better, but that doesn't mean that you're not going to learn your first tool. The rabbit hole that I sort of fell down with is initially feeling like a MyoBrace appliance was going to do it all for me. That it had to do, that because their slogan, and I'm a certified MyoBrace provider, but their slogan is straight teeth without braces. Well, that's a little misleading, because if your function is perfect, if everything is perfect, again, that hermetically sealed bubble, yes, that's true. Myofunctional therapy, whether it be MyoBrace or with a myofunctional therapist or healthy, whatever it is a tool to help you manage the muscles and help support breathing. I don't think it's enough alone to get the structural changes you need. And I learned the hard way, guys, that sometimes when you try to do this in children who are really crowded and their airways are really occluded, it's like trying to, pound a square peg into a round hole, and it just turns everybody off and they don't get better fast enough. So no matter what you do, I think you have to either find myofunctional therapists, have one working for you, or understand it yourself to support what you're doing. But you do need to find in children some way to change or expand their structure and get their growth back on track. So you should take some sort of expansion course. It doesn't matter what it is, what works in your hands. I also think getting basic bracketing skills is very important. In addition to clear aligners, but there's just some times that you need to use some bracketing. And in my experience, to get out of, because what happens is you're like, I have this one tool, and then it works for 8 out of 10 patients. And then those 2 patients, you're like, now what? So it's just a matter of spending time collecting rocks, collecting tools, and trying it. A lot of people, I think, want to be perfectionists before they even try. You just got to try, because that's how you learn. You learn from all your mistakes.
I'm thrilled to just share with our listeners, who I know a lot of them have taken Dr. Miraglia's mini residency, that we're just launched our advanced mini residency, which is going to be a live course, which I'm so excited for, and virtual October 1st and 2nd. But we are teaching the basic bracket and wires, so you can have that added to your portfolio. So
and I think
really
that is so great. And that's something we've been talking about in the endeavor too, that there's just not enough of basic bracketing live classes. So the fact that you guys are doing that, I mean, I would recommend that to everybody. Even if you think you're never going to put a bracket on a tooth, it's good to have it in your tool, in your toolbox.
So let's get to some of these questions. I know you answered a lot conversationally, but there are some specific questions that I want to address. And what is the appropriate age to first check for the airway? So like an airway specific screening, what age would you recommend?
I would like to 3. It's, it's interesting about like what you can learn a lot by using a PSQ. I use the Pediatric Sleep Questionnaire a lot. I mean, there's so many questionnaires out there. I like the PSQ by Chevron or Shervin, was it CHERVIN? It's a validated tool that's highly predictable for children. Yeah, yep. That's highly predictable for children. And in some cases, I know overnight PSG is the gold standard. However, the problem is the only thing they're screening for is sleep apnea. And to me, sleep apnea is like, now we're really bad, right? I mean, we gotta get the early stages of it. So the PSQ is my go-to for that. And again, then doing, a clinical exam, looking for, the phenotypes, narrow maxilla, no spacing, cross bites, even in the presence of spacing, retruded mandible. The big thing, one of the biggest things that I've learned in my journey is that the problem all lays with the maxilla and how retruded the maxilla is. So being able to see those signs, that's something else that the Endeavor is working on, ADA is working on. I have my own little cheat sheet that I'm sort of working on that I send to people, like pictures, like what do these kids look like? So you can tell a lot from those. I do love getting a low dose CBCT between 3 and 4. I'm pretty, I really sort of do it case dependent. If I see, a screening in a child, sorry, that's my dog,
That's okay. My dogs can't hear your dogs. I'm upstairs.
Right. Like a stage 3 or 4 melon potty and really just big tonsils and all these other things. I think the amount of information you get from that scan is so helpful. But I would say I routinely start taking scans on 4-year-olds. I do, again, take some low dose ones on 3. I don't repeat them. I mean, it's just to sort of get as much information as I can. And I'd like to follow them up, with, I don't know, those of you have a CBCT, by taking a scalp film, which is like minimal radiation. It's the scalp film that you take before you actually hit the go around. It's a great way to follow your patients in terms of airway growth. So if I can start a child in treatment, age dependent, as early as 3, 4, 5, that's my go-to. And then what we're doing in our practice now is, all right, so, we do an infant phonectomy. Now what? Do we not take a look at them again until they're 3 or 4? Do they disappear? No, I mean, this is like the hardest little, cohort to say, how do we help them? So yeah, we're sort of developing, we're sort of calling it our baby or infant myo program, where we're giving them, depending on what they can do, a trainer, spot dots, nasal clearing. Everybody learns how to nasal clear. Everybody learns how to nasal clear. You start nasal clearing and using some xylitol saline in your child when they're a baby, they're used to it. Nasal hygiene. We're teaching our kids to wash our hands. We're going to teach our kids to wash their nose, right?
Right.
So,
Nasal hygiene.
right, talking about, just little things, bilateral chewing, playing games with your kids. They should chew for, 5 or 10 times on one side, 5 or 10 times on the other side with their lips closed. These are all little developmental things we can do until they're sort of ready for their structural development.
And then
but it's a hard cohort.
Yeah, absolutely. What is the, do you do your own phonectomies or do you refer out?
I do. I do. Yes, I do. So I like being able to do them because I feel like I can get everything situated just the way I want to before. So for me, and again, this is just me, if it's an infant, we will do a same day infant phonectomy if it's a child who's really struggling. But I'm always working with my CLC. If, it's maybe a 3-week-old or a 3-month-old, we're really going to try to prepare them with lots of lactation consulting body work before, if we can. And so for my older phonectomies, which I kind of say, my functional Zoggy style phonectomies, for me, I address the structure first. I feel like I don't want to try to park the car in the garage that's too small.
Okay.
And
That was my next question, so that's
right,
great.
yeah, I mean, that's just my gut feeling. And again, I am not here to be preachy or say this. This is just how I've come to do it. So I feel like sometimes I can't even really get a good assessment of what the tongue is even doing when it's been living in a garage that's too small, and it's floppy and it's untoned, and it doesn't even have enough space in the anterior posterior. It's like they can't even put their tongue on the spot because their maxilla is so far back they can't find it. So a lot of times I suspect they have a tie, but I don't really get into it until I increase the structure, do some myofunctional therapy with them, and see, okay, there are some times where you really don't need to do a frenectomy. And that's awesome, right? And then the times that you do, you're really prepared to do it and then to follow them post-operatively.
Okay. Is there an at-home sleep study for kids that you recommend, home sleep study?
So there is, well, there's sleep image. A lot of my colleagues use sleep image or high resolution pulse oximeter. Okay. I am still on the fence only because, and I go back and forth, and this might totally change the next time we talk. I like to be very careful of distinguishing myself. I don't want to be a sleep medicine doctor. I want to be a dentist that does things that supports healthy sleep and airway. And I don't think that they're not useful, but I feel like then I am taking charge of their sleep, which is a very big chunk of responsibility.
Right.
So for me, and we also know, and I, spending time like talking to some sleep physicians who really get this, right? Who aren't like poo-pooing it, but really get this. There's so many things that can change in sleep that it's just so big. It's so big. And I know that by working with the structure and the function and everything that we do, that we can really improve it. I just don't know if I just don't know if it's my particular realm to it's like once when we're dentists or clinicians, once you touch that tooth, you own it, right? So once you start tracking and diagnosing the sleep, you have to own that. So, I rather know that we can really improve things and go based off of clinical symptoms and structural symptoms. That's just me. I might be in the minority, and that's fine too. And I might change my mind.
Right. But you're in the safe zone.
I'm in the safe
That's
zone.
okay.
Right.
That's okay.
And I feel comfortable there because I feel very comfortable in my domain and making quote unquote promises or goals that I believe I can hit. And, so that's kind of why I'm out of that. But I know that there's a lot of great things being said about sleep image and high resolution pulse oximetry for children. And I think the youngest, I don't think there's a approved under, I don't remember, but it's not very young for an overnight PSG yet, but I think it's coming.
What is the best way to educate other professionals about the importance of early airway assessments? I know that the ADA has a whole campaign going on here, so maybe you can give a high level.
Right, it's hard, especially physicians, especially pediatricians who are so incredibly busy and overwhelmed that, I have a wonderful pediatrician who is totally on board, and she has a hard time getting her colleagues to, in her practice, just they're really overwhelmed. So I think it's, just asking them, again, what harm could it be to take a look? Also telling them that, we are really here as we don't expect you, we can be your resource for the oral facial development, so you don't have to take that on too, but again, this is something that the Endeavor is working on, is pulling together some of what we, and by we, I don't mean me, because I'm not the best research, fine-tuned reader, right? Right. Statistics, I had to take it, but it wasn't my thing, but we being some like Steve Carstensen and Kevin Boyd and Mariana Evans, who live, breathe, and, sleep research, and can, sort out the junk from the good stuff, where we have a resource on the Endeavor where just for that question, you guys can say, here's a couple good articles that we know that will appeal to the medical community. So those are the kind of things we're working on. So stay tuned. Yeah.
Sure.
I mean, won't it be great? Like, just go, just go, and hopefully everything you need will be there.
Yep, that would be amazing. Now, I know you treat special needs patients. Any advice to a specific question was a doctor's treating a couple of autistic kids who really struggle with fixed appliances. Any suggestions? I know it's broad, but maybe
it's
some
hard.
highly.
It's hard. When he or she says struggles, does that mean it's? And so I guess the question is it hard but doable or impossible?
Right.
Because, parents of kids with special needs, things are a lot more difficult. And if you have, again, the parent on board for, we got to just sort of muscle through this, then it being difficult, it's okay. This is not, we can make it easy and fun, but it's not like we can snap our fingers, right? You have to put something in the mouth, and some people adapt to it more than others. And I have been wearing expanders. I'm on my whole other airway journey. So I realized that I am a cranky, terrible person when my mouth is uncomfortable.
Right.
I didn't know that about myself.
Mm-hmm.
Right. So it's hard. So I think if they're struggling, but doing okay, to just kind of bear down and get it done. Right. One of the things that I've been using a little bit more for special needs patients is Dynaflex. Again, this is not like average. I just kind of am playing around with this. There's an appliance that Dynaflex makes that you put in, and it's like self-activated. So you put it in, and it's going to give you, it's not going to give you tons. You might have to use more than one, but it's going to give you about 5 millimeters of expansion. So it's sort of spring loaded, and it's fixed, but it covers the palate. So you set it and forget it. And
is that their motto? Because that's a good one.
No, that's mine.
That should be their motto.
I do that. I do a lot of that crock pot, like just we're gonna set it and forget. Somebody's saying which appliance from Dynaflex. I think it's called the it makes me think of, for those who are old enough, the Bassmatic 2000 from Saturday Night Live. Do you remember that?
I don't.
I'm really dating myself.
But I'm older than you. I just must have not caught that one.
It's like the Dynaflex 2000 Max. So here's the cool thing. If you go to Dynaflex, and again, I have nothing to do with Dynaflex. I pay my lab bills. They don't know me from Adam. But if you go to their catalog, they have like a really nice online catalog that you can print out. It's probably one of the nicer catalogs in terms of like, oh, I kind of see what this looks like. I'm going to give it a try. And it's the Series 2000. And there'll be a few, and you'll see that there's one that's fixed. And they're also really nice. You can call them and be like, yeah, I've never used your appliance before, but I heard it's great. They will talk you through it.
Wonderful.
That's they're actually really helpful. Yeah.
So I know we're coming up at 9 o'clock. I do want to share that brochure, because now I can share my screen. So you helped create this, right?
No,
The
I didn't. I
Oh,
love
I thought
Steve.
you
No,
did.
no,
I'm
this
sorry.
was actually before my time, but I
Okay.
am working I think you're confusing, but I love, geez, this is like the best. I'm so glad you have it up.
Mhm.
Steve Carstensen and I and the Endeavor are working on sort of the next part of this, which
Okay.
is an ADA supported sort of universal screening tool. Wouldn't that be
Excellent.
great?
That would
Right.
be wonderful.
Right.
Mhm.
So that is what we're working on, that sort of has a couple pictures, a couple questions that's sort of universally supported. Right. So that might have been why you did it. No, but Steve Carstensen and Glenine Vargas did this. I think, I mean, all of us who are in airway know how hard it is to boil down everything we're trying to say in a concise message. It is
Right.
not easy.
Right.
It's so hard. I love this brochure.
Right.
I just
And I
think,
think there's a code here. I'm not sure if it's still active. I know it was good till sometime in May. So give it a try. It's 15% if you want to get the brochures. But what I like about it as a hygienist too is when you have that ADA seal, tell this to your patients to show their pediatricians,
yes,
right? It's like all of a sudden, it's not just some marketing piece. It has the
that's right. It's
ADA
from the
seal.
ADA.
Mhm.
And you
And
know
I,
what? And then it's their responsibility. You have told them that this is something that's being spoken about in the
exactly.
ADA, and that they, you don't have to tell them this, but then they kind of have a responsibility to get on board for their patients.
That's what
Yeah,
I
I
thought
saw
was really.
somebody asked, I just saw this pop up, which
Sure.
CBCT. I use the iCat Flex,
Okay.
and it
Thank you.
has the ultra low dose setting on it.
Excellent. We have our mini residencies, just in case you want to dive in and start with us. We'd love to host you. Dr.
I would
Miraglia,
highly recommend it.
thank you. He does such a great job of just simplifying things, and you can get started. And we're all for learning other methods and methodologies and anything that you're comfortable with using. But we feel like this is a really great start. Or even if you're advanced in your career, I know Dr. Ballinger, you're going to take our course. So it's
I
really
am.
not meant for beginners. It's just
No,
kind of meant to broaden, because you can never learn too much, right?
I think what happens is you start learning. Like, I love his course for this reason, because it's going to get you started. It is going to get you started. And then you might take somebody else's courses and try that. And then you might be like, oh, wow, I just came up with a hybrid approach, or not. It doesn't matter. But I love taking other people's courses because I always learn something. And there's always, even though I may have my favorite go-tos, like I said, there's always that 1 out of 10 page. It's just great to see what other people are doing and what experiences they're having and trying. And the good thing is when you get a little bit more, it happens, or it'll happen over time, but when you get a little bit more efficient and fluent, it's really fun to kind of like see what other people are doing and kind of test it out in your own hands and like see how it works. And yeah, there's just so many really smart people doing this that have so much to share. So I think the more we learn, the better.
And like you said, like Dr. Lisa Baines, who you mentioned before, she was an alumni. So it's so exciting to see how people can just take this and really, really grow with it. And more importantly, help their patients grow with
Yeah.
it, obviously. So
And
we try to do our mini residencies monthly. We're not having it in August for the summer break, but we will have our advanced course in October. So
that'll be
if
your
you're,
bracketing course, right?
that's the bracket wires and fixed expanders in adolescents and later teens from 13 to 17. So it's a very specific
Really,
technique driven course. We highly recommend, it's not a prerequisite, but just highly recommended that you take the pediatric mini residency first, so you have the baseline foundation, unless you already have experience in airway. So we hope to see you at one of our events. We're also thrilled that we now have a myofunctional therapy course that's designed specifically for the hygienist to implement this into the dental practice. So we're not training SLPs or hygienists to open up their own practice. It's how to implement this in the existing practice. So we highly recommend actually the doctors investing in their hygienists to become myofunctional therapists in their practice.
right.
So
And then what do you do? right? This is it,
Yeah,
right? This is perfect.
exactly.
Right?
So, both you and Dr. Miraglia are highly agree that you really can't be effective with treatment without myofunctional therapy. It's a must-have. So we're trying to make it easy for you to implement this. So please visit our website. You can go to /myo or just our main site and it will pop up. So we have Brittany Sierra, who is actually featured on James Nestor's podcast, and Carice Laguerre. She's a published author, and both are really passionate and easy to understand and deliver instructors. We do have, for the adult cases, I know a lot of pediatric interest here, but I just want to let you know we do have a course June 3rd, and it's more like a workshop. And we really enjoy this because it's literally case review after case review. That's the whole course. So you're going to learn kind of the expansive camp versus the retractive camp. You'll see how Dr. Miraglia kind of unravels all the ClinChecks. It is a clear aligner case review, but we do accept only Invisalign cases for this particular course, just because of HIPAA and compliance methods. But you can apply this to other clear aligner systems as well. So that's June 3rd. You can either join as a submitter or an auditor. So please check that out. Follow my blog. I'm doing an expansion myself, and I know what you're saying about being cranky, because the more I'm expanding, the more difficult it's getting. And I see the difference, as I'm progressing in my smile from here to here. But follow my blog and come join me. And patients are finding this very helpful. I'm getting a lot of feedback that patients like to see this blog. And please follow us on Instagram, Facebook, and then we also have our archived airway chats on YouTube. Speaking of adding sleep to your practice, in case someone's interested in this, we want to make it simple for you. We're not saying you need to become a sleep dentist, but Dr. Richard Downs has a really nice balance that he's going to share with us of just some added diagnostics. So Dr. Ballinger, you may want to join that, check that out. That's going to be June 16th. We're going to take a break, and we have some really, really exciting guests coming up in the fall. We have over 200 airway dentists now, so I couldn't be happier about this. And after you take our course, we'll put you on the map. I think you'll get a green dot soon, but you get an honorary one, Dr. Ballinger. So you can find a locator. If you're looking for airway-centric, airway-trained dentists from Dr. Miraglia, for either for yourself or for people relocating or for loved ones, you can go to our locator. It's airwayhealthsolutions.com.
This is so needed and so great.
/locator. Thank you. So that's it. That's our contact information. I will send some follow-up information in the email. I know some of the people registered and they didn't get to watch it live, but hopefully a lot of your questions were answered conversationally. And this is your website, nurturegrowdentist.com. You're based where in Massachusetts again?
I'm in Western Massachusetts.
Okay.
So we are on the opposite side of the state of Boston, but we're only about a 2.5-hour drive. And I get a lot of patients from New York State and Vermont and Connecticut. So we're kind of accessible to a couple different states, and for better or worse, a lot of patients do have to travel right now. I hope that that's not always going to be the case, and there'll be lots of green dots everywhere, but we certainly welcome people that want to take the ride. I just want to leave with saying, I don't want to take up, I just want to tell anybody, that if you have thoughts of pursuing this and really stepping out of the box, and even so, my practice now, I've completely dropped the handpiece. I don't do any pediatric dentistry anymore, and it was a really scary thing to do, but you can do it. So I think I'm not advocating that everybody has to do it that way, but if you sort of have a hunch or an inkling that you want to do it, you can do it. And
you're living proof, and that's why I'm so glad. I knew we would go over tonight. I just knew it. I just knew. I feel like we could just, okay, let's do round 2 and really dive up our sleeves into some of the nitty gritty.
Anytime I'd be more than happy to, but I just want, there's so many barriers that we hear, whether it's from our colleagues or, the dental profession itself, although it's changing, or our families, or whatever it is. If it's something Lauren and I were talking earlier, you just have to set your intention, and then you have to put your seatbelt on, because sometimes it comes so quickly and so fast. You're like, oh my gosh, I wasn't expecting that. But for me, it was the best decision I could have made.
And not only for you, Dr. Ballinger, but for your patients. I mean,
Uh,
think of all the people that you've helped. And I know that that's really why you're here and sharing your story. So thank
yes,
you.
yes, I'm so happy to be here, and I wish we could see everybody in person, but hopefully one day soon.
One day. All right. Well, thanks again, Dr.
Thank
Ballinger.
you,
Thank
Lauren.
you all for joining us. And we really love your honesty and sharing your story. So we'll see you next time, June 16th on Airway Health Solutions. Take care. Good
All
night.
right. Bye,
Thank you.
everybody.
Bye.